Hello, I'm Juan Valle. I'm a medical oncologist at the University of Manchester and the Christie in Manchester, UK. I'd like to thank Kathy and the whole team at Neuroendocrine Cancer UK for the kind invitation to come and speak at this summit. The task I've been given is to talk about treatments across the neuroendocrine cancer spectrum, particularly with a focus on chemotherapy and targeted therapies. Here are my disclosures. So I think the first thing to say is that every patient is an individual, and I just wanted to give you a sense of the kind of things that we need to assess as clinicians before making any treatment decision. There are things, of course, that we need to know as a doctor. And I'm going to cover things around the cancer in a little bit more detail, but what we need to know is what is the degree of differentiation, and I'll explain this. What is the grade of the tumor, and I'll explain this. But also, where did the cancer start? Where is the primary? Because the treatments are different, whether it's from the lung or the pancreas or somewhere else in the digestive system. We also want to know how advanced it is, or the stage of the cancer. And there are other things that we want to know when making treatment decisions, like, is the cancer actually getting worse and needs treatment? Do we have what we call liver predominant disease, so more disease just affecting the liver, and sometimes we have to target the liver separately. And some of you will know that neuroendocrine tumors can produce hormones and they can cause symptoms, and that's something else that we need to know because it doesn't affect everybody. So I will come back to some of those very specific issues around the neuroendocrine tumors and carcinomas shortly, but it's also important to know patients are not all the same. So some patients have different levels of fitness, some more fit than others. Some patients have a number of other health problems, diabetes, high blood pressure. These things are very common, and sometimes we have to take that into account when we're selecting the best treatment. We know that sometimes medications can interact with each other, so it is important to know what medications are being taken, both prescribed, but sometimes over the counter, and that even applies sometimes to supplements, because even supplements can sometimes interact. We want to understand what patients' preferences are. What is it that you want to get out of the treatment? What's the trade-off in terms of side effects and quality of life? And that conversation also comes down to what it is that we're trying to achieve, and that is together as a partnership. So let's focus on the cancer itself. One of the most important things that we need is to get a biopsy. And our pathologist looks at the biopsy under a microscope. And the first thing they decide is whether the neuroendocrine neoplasm, so this is a term that's used for all the different types of entities, is either well differentiated or poorly differentiated. On the slide, I've shown you a pathology sample on the left of something very well differentiated, by which we mean the cancer is very orderly. It looks a little bit like the normal tissue that it came from, a bit like a tidy bedroom. And on the right, a very disordered cancer. So the cells are all clumped up together. They're no longer looking like the original organ. They look much more messy, much like an untidy teenager's bedroom. So the first thing we decide, is it well differentiated or poorly differentiated? The next thing is to then give it a grade. Now we get a grade to give an idea of how aggressive the neuroendocrine tumor or neuroendocrine cancer is. And we do that by doing a special stain that picks up the cancer cells that are dividing at any given time. And those can be seen as little brown spots on a background of blue spots. So blue spots are all the cancer cells. The brown ones are the ones that are actively dividing at any given time. You can see here there are 4 different pictures. One at the far left is a grade 1 tumor, so only a very small number of cells are dividing, very few brown spots. We call that a neuroendocrine tumor, grade 1. Moving towards the right, you can see we go into grade 2, where between 3 and 20% of the cells are dividing at any given time, through to grade 3, with more than 20% of the cells dividing. And if it's poorly differentiated, quite often we see very high percentage of cells dividing at any given time. It can even be 80, 90, or close to 100%. And those are the most aggressive neuroendocrine carcinomas. The other thing I said was important is, where does it come from and what stage is it at? Now, we're going to establish that from a CT scan, maybe an MRI scan, or even a PET scan. Now, mostly we're now using gallium PET scans. Some of you may have had an octreotide scan. All of those scans together give us the information that we need to know. Where did the cancer start? And then how advanced is it, or what stage is it at? If it's early, it means that the cancer is very small and is localized to where it started within the organ, and it hasn't spread anywhere else. And often it's possible to do an operation to remove it. Sometimes the cancer grows a bit bigger and gets stuck down into some of the tissues around where it started. And then it can be that it's no longer possible to remove it. So we call that locally advanced. It's no longer operable. And then, of course, in more advanced stages, we know that the cancer can then spread to other organs. We call this metastatic. So that's stage 4 disease, or metastatic. We'll come back to these terms later on. Why is this important? Well, because there are different treatment options, and the treatment options, in fact, often relate to where the cancer started. So just look at this table, which summarizes some of the guidelines that we're currently using. To the far right, we have a column called lung. And for patients with lung neuroendocrine tumors, you can see there are some options. The ones in brackets are ones that are currently being used but haven't yet been approved because the evidence is not quite as strong from clinical trials. On the next column along is something called PanNet. This is shorthand for pancreatic neuroendocrine tumors. And you can see here that this has the most of treatment options that are available. And then SINet means small intestinal neuroendocrine tumor. This is one that starts somewhere in the small bowel. And you can see here that we've got a different number of treatment options, but not every option is available for every type of neuroendocrine tumor. Now, the reason for that is because sometimes the trials haven't been done, but other times the trials have been done and they've shown that there hasn't been any benefit. I've highlighted on this slide the chemotherapy and target therapy options that we're currently using on the green rows. The bottom row, chemotherapy, is something we often use for pancreatic and neuroendocrine tumors. Moving up, sunitinib is only approved for use in pancreatic neuroendocrine tumors. Everolimus, which some of you will have had, you can see is available for a wider group of patients, including small intestinal as well as lung neuroendocrine tumors. I think at this point, I just want to circle back to the stage of the cancer to highlight that the treatments that we're talking about in terms of chemotherapy or targeted therapies apply mostly to patients who have advanced disease. I already said that if the cancer is early, then we would recommend surgery if that is safe and possible in a specialist team. So what I'm going to do over the next few slides is just to shine a light and focus on 4 recent developments. Please forgive me if your favorite drug is not included on this list. I didn't want to have a presentation that is very, very long, giving lists and lists. I wanted really just to highlight on what currently is breaking through and is quite exciting in the field. 2 are about chemotherapy, so that's temozolomide and capecitabine. I'm going to share with you some new information. I'm also going to highlight the NET-02 study, and I'll explain what that is in a moment. And then speaking about targeted therapies, I will focus on 2 drugs, one called lenvatinib within a trial called the TALENT study, and surufatinib through 2 studies that have recently been published. So let's get started with chemotherapy. There's a combination of chemotherapy that's been doing the rounds for a few years now called temozolomide and capecitabine. This is a new version of an old combination which was all given intravenously and was very toxic. Temozolomide and capecitabine are two chemotherapy drugs that are given as tablets. So they're very convenient for patients. And the way that the regimen or the recipe of the chemotherapy drugs is given, on the whole, it's very well tolerated. And so patients have very few side effects. Now, just before I talk about this small study, I want to orientate you on this particular graph. You can see on this graph that there are a number of different bars. Each bar represents one patient. And we've taken measurements of the cancer, and everybody starts at 0. As they have the treatment, we then remeasure the cancer. And if the cancer is getting smaller, then you can see that it goes into the minus side. So minus 20%, minus 40%, and so on. So going down, patients get better. If, however, the cancer is growing and it's getting worse, then the bar goes up. Now, this small study was presented in 2011, so it's quite some time ago. It was only 30 patients, and all of the patients in the trial had pancreatic neuroendocrine tumors. As you can see from the graph, a lot of patients got better, so the bars went down, and there was an improvement across the board. And when the cancer was under control, it then remained under control for at least 18 months. So this was very promising, but there was a question, and that was, why are we using 2 chemotherapy drugs when maybe one may be enough? Maybe having 2 drug combination added more toxicity. And the only way we would know that is to have a randomized trial. So this next slide shows the results of the E2211 clinical trial. And this compared 2 groups of patients. One group had temozolomide on its own, and the other group had the combination of chemotherapy with temozolomide and capecitabine. What did the trial show? Well, in terms of controlling the cancer, in terms of shrinkage, the results were very similar, whether you used 1 drug or 2. But on the right, you have some special graphs that we call Kaplan-Meier curves. What these curves do is they show every time that a patient deteriorates or gets worse, the step goes down. And another patient's cancer gets worse, step goes down yet again. So what we'd like to see is the steps going down more slowly. If the steps go down very quickly, then it tells us the cancer is getting worse very quickly. So on these graphs, the one on the top is better than the one on the bottom. And as you can see, in terms of what we call progression-free survival, so that's how long the cancer was under control, as well as overall survival, patients having the combination chemotherapy did better. So this study then made it very clear to the oncology community that we should be using 2 drugs instead of 1 when using this combination chemotherapy. I'm going to switch gears quickly to another type of chemotherapy focusing on patients with poorly differentiated neuroendocrine carcinoma. Remember what I said, these are the most aggressive ones. And for many years now, we've been using chemotherapy because when a cancer is very aggressive and many cells are dividing at any given time, in fact, chemotherapy, we know, works by attacking cells that are actively dividing. Now, for many years, we have been using a combination of chemotherapy drugs called platinum and etoposide. Platinum covers drugs like cisplatin or carboplatin and etoposide. So there's 2 different chemotherapy drugs. And we know in general that patients tend to have a good response to treatment, by which I mean there's good shrinkage of the cancer, but eventually the cancer gets worse. And then what? Well, in fact, even in 2020, there are no established what we call second-line treatment options. And the reason for that is the clinical trials just haven't been done to inform us. So although there are drugs that sometimes people try, we don't actually know which is the right combination or which are the right drugs and what are the best ones to use after people have had platinum and etoposide chemotherapy. So I'm not presenting you any results on this slide of the NET-02 study. In fact, I'm using it to advertise a study that's currently open. So in this clinical trial, which is running only in the UK, we are inviting patients who have got a poorly differentiated neuroendocrine carcinoma, so that aggressive group of cancers, who have already received cisplatin and etoposide chemotherapy, and then the cancer gets worse. So that's the time to take part in the study when a new treatment is needed. Patients who wish to participate are then allocated into one of two different groups, and that's done completely at random, a little bit like tossing a coin into one group or another group. One group gets a drug called docetaxel, which has been around for a few years, and the other group gets a combination of two chemotherapy drugs called liposomal irinotecan and 5-FU and leucovorin. I'm sorry, that's a very big mouthful, but we call it Naliri and 5-FU for short. What we're hoping to find out from this study is which of the two treatments is the preferable one to keep on developing further to be used in the second-line treatment of patients with this condition. And sometimes the two different treatments might shrink the cancer by the same amount, but maybe better in terms of side effects or quality of life. So we're collecting all of that information. So this study is currently open in the UK, and I'm grateful to all patients who have currently already enrolled to participate. Let's now change focus to targeted therapies. So this is a little bit of a complicated slide, and I'm just going to talk you through it. At the top of the slide, you have the outside of the cell. At the bottom of the slide is the inside of the cell. And the gray row of what looks like tiny little mushrooms are in fact the cell's surface. And what happens in our bodies is that there will be chemical messages that will be going through our bloodstream, and those chemical messages or proteins will then dock into what we call receptors. These receptors are colored here: pink, red, green, yellow, orange, and blue. They're different receptors for different proteins. Once the right chemical triggers the receptor, it then sends messages to the inside of the cell and tells the cell that it should divide, it should form new blood vessels, and instead of just becoming an old cell and dying off as it should, those cells can then keep growing, and then they can start invading, and that's how cancer cells develop and get established. What we do know now is we have a much better understanding of what it is that's triggering these receptors and how to target them. One of the treatments that I highlighted earlier on that we've been using for a number of years is a drug called sunitinib. This is approved for patients with advanced pancreatic neuroendocrine tumors. And you can see here that sunitinib can block a number of different receptors, in fact, about 5 out of the 6 that have been highlighted. So by using this drug, we can block those messages from getting into the cell, and this is why it's been shown to be effective in pancreatic neuroendocrine tumors. You can see in the gray boxes at the top the names of lots of different drugs that are being looked at and are being studied in neuroendocrine tumors. So another one I'd like to highlight, which is relatively recent, is a drug called lenvatinib. Now you can see here that this targets a slightly different pattern of receptors than sunitinib did. So what does it do? Well, there was a clinical trial of lenvatinib called the TALENT study. This was led by a group in Spain, but the UK was participating. So if we look at patients on the left side with pancreatic neuroendocrine tumors, you can see a lot of these bars go down. That means we got tumor shrinkage. In fact, there was tumor shrinkage in about 40% of patients. And this is very encouraging. On the right is another graph of patients who had neuroendocrine tumors from elsewhere in the digestive system, so not just the pancreas. Here, there was a lot of bars that were going down, but they were not quite as dramatic as we saw in pancreatic neuroendocrine tumors. Here, the response rate was around 18 to 19%, meaning that for 18 or 19% of patients, the cancer shrunk down. Now, what was a little bit disappointing is that the drug company who produces lenvatinib then decided not to develop lenvatinib any further in patients with neuroendocrine tumors. However, there is a new compound called surufatinib. It used to be called sulfatinib, is now called surufatinib. I'm sorry, these names are very complicated. Once again, you can see that they target a different pattern of receptors, and these again have been tested in clinical trials. The first trial is called SANET-P, and this was looking at patients with pancreatic neuroendocrine tumors and was a randomized trial. So in this setting, some of the patients received surufatinib, so the real tablets, and the other group of patients received a dummy drug, a placebo. And the study then compared which group of patients did better. And as you can see here, this is measuring the time to the cancer getting worse. In fact, patients receiving surufatinib had delayed cancer progression by about 66% or 2/3. There was a different study done by the same group of investigators in non-pancreatic neuroendocrine tumors. Again, using surufatinib, again, this was a randomized study. You can see here again that patients on surufatinib did better, maybe not quite as dramatic as patients with pancreatic neuroendocrine tumors. In this case, it delayed the progression by about 34%, so 1/3 instead of 2/3. Now, what were these patients with non-pancreatic neuroendocrine tumors? Well, on this slide, you can see that that was made up of patients where the cancer had started in the gastrointestinal tract, so in the rectum at the bottom end, stomach, the small bowel, colon and appendix, but also it included patients with lung neuroendocrine tumors, as well as neuroendocrine tumors of the thymus gland, which sits behind the breastbone, the liver, as well as others where it was not known. So what was encouraging here is that it seemed to be active across a wide range of patients and types of tumors. So where are we up to with this drug? These studies were done in China only and relate obviously to patients from Chinese background. I can tell you that the study is about to open in the UK because we also want to see how much Western patients, particularly UK patients, benefit. And so this will be opening in the next few months here in the UK. Many people talk about precision medicine, and precision medicine means that we move away from the picture on the left. Here, all patients are treated the same. So we give the same treatment to everybody. Some patients we know respond to treatment and others do not. And wouldn't it be nice to be able to split patients into much smaller groups where we can then identify the right treatment for patients according to something in their tumor, whether it's a gene, a protein, or something that tells us that they're more likely to respond to one treatment or another. Well, this precision medicine is already happening in cancer care, in oncology, in many different cancers. And it relies on us using samples or biopsies from the cancer to look at the DNA, the messages that make every cell in our body, the RNA, the proteins. And for some types of cancer, we have been able to find special groups where there is one particular genetic abnormality that is driving the cancer, that's making the cancer worse. And then we can give a treatment specifically to block that genetic abnormality. We're not quite there yet with neuroendocrine tumors, but many centers are undertaking some of this molecular profiling, looking to see whether we can identify some subgroups. So with that, I'd like to take you to the take-home messages. I think I've probably shown you that every patient, as well as every cancer, is quite individual. And as clinicians, obviously, we want to try and make sure that we get the right treatment for the right patient at the right time. We do have an increasing number of treatment options for patients, and you will hear across this summit about other treatment options, surgery, PRRT, which is peptide receptor radiotherapy. You'll hear about embolization and other types of radiotherapy, for example, as well as the treatment options that we've talked about today. I think it's important just to remind everybody that if we do find a cancer early enough, surgery gives the best chance of cure. If we focus on the purpose of this presentation, chemotherapy, I've shown you that a combination of temozolomide and capecitabine is now an established option for patients with well-differentiated neuroendocrine tumors. The NET-02 study is open and aims to increase treatment options for patients with poorly differentiated neuroendocrine carcinomas who have previously had platinum and etoposide chemotherapy. We already have some targeted therapies, sunitinib and everolimus. I've shown you that others are coming along. Lenvatinib, we know, may not be developed further, but seems to be an effective treatment. And surufatinib will be coming to the UK in clinical trials and certainly looks very exciting. And it's only by doing this clinical research and encouraging both clinicians and patients to participate in clinical trials that we can develop some of these new treatments. So on my acknowledgement slide, I would like to really thank all of our patients who choose to participate in clinical research, not forgetting their families and the carers for making it possible. I'd also like to acknowledge Neuroendocrine Cancer UK, the charity with whom we work quite closely and who also fund some of our ongoing research questions. And with that, I'd like to thank you for your attention, and I hope you enjoy the rest of the summit.